When it comes to blood in trauma, we used to refer to our intervention as massive transfusion protocol. In my center, we're kind of moving more towards a terminology of a massive hemorrhage protocol. Can you explain why we are preferring that new terminology?
Yeah, we've done the same. We've moved to massive hemorrhage protocol, and I think it's because the focus should be on stopping the hemorrhage, and just by transfusing blood is not going to fix the problem, right? So it's a as it's named a protocol, but it's a constellation of things that we do. So our MHP includes a balanced resuscitation with blood products, but focusing a lot on coagulopathy. I think that might be another shift towards early correction of coagulopathy as being recognized as crucial, not just red cells, but plasma platelets, cryo. And so our MHP includes that, but it also includes TXA, calcium, activating cell salvage if we are going to the operating room, making sure that we have appropriate labs, including viscoelastic testing, so that we can focus our coagulopathy correction. So I think by calling it an MHP, it kind of gives this broader picture of all the things we need to do to fix their hemorrhaging, as opposed to just focusing on giving blood products.
I know there's been a lot of focus on like getting blood fast and transfusing rather quickly. Has that shifted? And can we do harm with just rapidly infusing blood?
Generally, in the setting of hemorrhagic shock and trauma, it's a necessary evil. I think we are very fortunate to have whole blood available in our system as well as pre-hospital. So I mentioned our helicopter system, our critical care ground transport has whole blood as well. So oftentimes our patients have already received 1 or 2 units of whole blood, which includes the plasma and platelets that we mentioned need to be focused on early. And often they get pre-hospital TXA. So the resuscitation's kind of been started ahead of time. Often, part of the reason that time is of the essence in getting the bleeding to stop is that if we can give the patient just the blood products they need and no extra, that's going to do them a world of good in their recovery and their risk of complications. So we certainly do see adverse effects of massive hemorrhage, which are usually going to be cardiopulmonary complications, especially as our patient population gets older and sicker and have cardiac pulmonary disease already. They're not going to tolerate it very well. But even young, healthy people, you're going to max them out with a massive hemorrhage protocol as far as their heart and lung function, and then require more time on a ventilator, prolonged recovery, higher risk of infections. And then the other concern is like abdominal compartment syndrome from over resuscitation and having kind of too much volume on board there. So definitely complications.
Yeah, and that kind of hits the other question I was going to ask too is like, what is balanced resuscitation, and can you do damage with like too much fluids as well?
Yeah, ATLS and part of our resuscitation strategy, and as I mentioned, we're fortunate to have the pre-hospital whole blood, is to avoid a lot of crystalloid. A patient who's bleeding needs blood, and giving them not blood is just going to water down all their coag factors and contribute to hypervolemia. So we do try to avoid crystalloid. And then the balanced resuscitation is more of the concept of the 1 to 1 to 1 red cells, plasma, platelets. These studies kind of originated in the military, but have really borne out in hemorrhagic shock that if you don't have whole blood, that's what you would start with.
Okay.
If you do have whole blood, it already has all of those components. So generally, our MHP includes whole blood. We use up to 6 units. Then we move to the 1 to 1 to 1 red cells, plasma, platelets. And then we move to viscoelastic testing guided resuscitation. So we have TEG at our institution. We would, once we get those results back, focus our blood products on correcting the coagulopathy that we see in that test. So that's what we mean by a balanced resuscitation, is making sure they're getting all of those blood products and then tailoring once we have the info to just what they need.